So here we have Dr. Jeff Sippel.
Hi.
Dr. Sippel is an associate professor of clinical medicine, Denver, Division of Pulmonary Sciences and Critical Care Medicine. He completed his pulmonary fellowship at Portland. At University Colorado Hospital, his primary interest in research is in the clinical informatics, moving toward population health and striving for quality improvement in the high-risk pulmonary population. Welcome, Dr. Sippel.
So thank you all very much for having me here. I really appreciate spending some time with you all. I don't think that my slides and the things I wanted to mention are going to take 45 minutes necessarily, so there's lots of time for questions. As mentioned, you can write them down on the cards and we can do them at the end, but also if there's something that somebody wants to, interrupt, redirect, ask questions real time, that's fine as well. And so I'm going to kind of go methodically through these, but there's plenty of time for sidebar discussions and things like that. First thing I want to do is acknowledge Dr. Tom Petty. I was honored to first meet him in 1991, and the things that he did in pulmonary medicine were actually all even before 1991 when I met him. And so the three or four highlights that I just want to point out to you are, in hospitalized patients, there's acute lung injury, we call it ARDS, and it involves many to most patients in the intensive care unit. He was one of the first ones to ever describe the condition. In addition to not only describing it, he pioneered some key therapies for that type of a lung injury. That in and of itself is a huge accomplishment. He also promoted and validated the benefits of pulmonary rehabilitation, which you'll hear more about today. And so, again, in and of itself, a huge accomplishment. And then also portable oxygen use and the benefits of portable oxygen. He also was a key player in promoting and validating that topic as well. And then to end it off, he trained quite literally hundreds of pulmonary physicians. At one point, I believe 15% of the division chiefs around the country had trained under him. So quite an accomplishment, quite a wonderful individual, and I'm honored to be here speaking at his conference, and just wanted to make sure that you all knew his brief history, which you may have heard before, but wanted to give you those highlights. Thanks. And as you can tell, I do need practice pushing the buttons here. So I am, on one hand, the keynote speaker. On the other hand, I'm actually not. So I want to make sure that you know who you're going to be hearing from later today, because these are, in a good way, the true experts on what you will be able to learn about today. And so Patrick Dunn will be speaking about Medicare and home respiratory equipment. Gary Schroeder, yoga therapy, and I'm going to mention some non-traditional things as we go along here that I think are worth considering, including things like yoga therapy. Robert McGee, a thoracic surgeon from the university. Bella Wong, Sue Schmid, both patients with lots of experience and things to share with us. And then Dr. Jeannie Youngworth in palliative care, also at the university. So I appreciate being able to be partnered up with these awesome speakers because they'll have lots of great stuff to share as well. So what I'm going to do is, I think you guys might have some notes that were my slides, and I've, of course, changed a lot of stuff. So I'm going to be going a little bit off script here, and because I looked at the slides a while ago and I thought, wow, these are just pretty darn boring. And so I wanted to just throw in some perhaps more relevant things. So what I'm going to do is, throughout the talk here, mostly at the beginning, I'm going to tell some patient stories of people that I have met and had the good fortune of working with. And so the first one I'll mention is a 52-year-old gentleman who works in the healthcare profession, and he had a year of cough. And if you really drilled down on things with him, he actually had more symptoms than the first, symptom mentioned as cough. And so ultimately, when I saw him, he was able to walk about a block is all. And the breathing tests, as was mentioned just a few minutes ago, spirometry, which you guys could do here. One of the numbers you get out of spirometry is the thing called FEV1. And his was initially, when someone saw him, 3.5 liters, and a year later it was 1.7 liters, which is a huge drop. And so we were wrestling with, well, what's the presumptive diagnosis and what got you here and what's bothering you and what do we need to do now? And so the keys to this gentleman's case, and there's going to be bird pictures throughout this, I'll explain that in a minute, is he came to us with a certain diagnosis that was going to be pulmonary fibrosis. He worked in radiation, and so maybe radiation exposure and things like that. But in a good way, we challenged our assumptions, and we landed ultimately on the correct diagnosis. We came up with the appropriate and best therapy for him. And so those were key things, and I'm going to mention that a few times today. And lastly, for this gentleman, he was really quite the stoic patient, and I won't say he did himself a disservice by, sitting on his symptoms for a year, but we'll merely acknowledge that prompt evaluation has a role. If you're uncertain how you're doing and what's going on with you, that's what we're here for, is to help answer questions, challenge our assumptions, validate what a diagnosis might be, and then craft a care plan moving forwards. So I wanted to point out in this gentleman those 4 key things. And so a year later, he's returned to regular bicycling and gym workouts and all those kinds of things that he really enjoyed doing. So we'll call this a success. I also want to underscore that everyone has their own definition of success. So as you think about yourself and where you are in life and what you're doing, you have your own definitions. So it's not fair for me or anyone else to give you that definition, but make sure you spend some time thinking about that. That's also what a lot of the other speakers today are going to talk about as well, is you as the center of what's going on here. So we're going to have some bird pictures throughout because for me, they're pretty inspirational. This is an eagle that we were in Alaska earlier this year, and I spent several hours watching this one eagle over the course of several days, and it's ridiculously difficult to take pictures of. And so this is the best one that I have, and as you can tell, it's not even fully in the frame, of this magnificent bird just swooping out of the tree down towards the water. And so it was just really fun, very difficult to take. And then also with birds that you'll see coming up here in some other pictures, they're very adaptive creatures, and they have sometimes a very specialized niche, and they figure out how to play to their strengths. And so I think that's an important aspect for all of us in life, knowing that today we are actually not as young as we were yesterday, and so that we need to continually think about, well, what can we do to adapt to make sure that we thrive in whatever environment that we're in. So the next patient I want to share with you is a 73-year-old who had a few years of progressive breathlessness that were not terribly dramatic, and then she moved to Colorado, much higher elevation than where she had previously been living. And so perhaps this kind of accentuated some of her symptoms, and she quite literally could not even walk up the stairs to get to her apartment. And the puzzling things were things looked like COPD, sounded like COPD, yet she had never smoked. And but as a child growing up, she had a lot of biomass stove smoke exposure, which means quite literally the entire house was full of smoke, not properly exhausted where she grew up. It was in Iran. And so this was probably her risk factor that we identified for something like COPD. And so again, in her, the things we accomplished were validating a correct diagnosis, correct therapies, and I think the most important thing for her was actually pulmonary rehabilitation. And so you'll hear a fair bit about that today, and it was quite key for her to be able to get back to enjoying family activities, walking in the neighborhood, participating in family outings and those types of things. This was the same eagle as it flew away from me. A fun picture, and again, I've got hundreds more which are not good, but thought I would share that one as well. And then also, again, the headline here is everyone has their own definition of success. So make sure that, again, we all focus on that. I was hesitant to include this story of this patient, but really felt that, you know what, this is real life here. A 63-year-old gentleman who was a former smoker and had several months of breathlessness and a pleural effusion, which is fluid collecting around his lung on the right side. we were able to help him out by draining the fluid a few times from the right chest, and ultimately our thoracic surgical colleagues, of which you'll meet one later today, Dr. McGeed, one of his partners, participated in the evaluation and care of this gentleman and did a diagnostic and therapeutic procedure, and we ended up with a diagnosis of mesothelioma, which is a cancer of the lining of the lungs in this patient. And so a question that I struggle with is, how do we get to success with a diagnosis like this? Because there's lots of things that we see in this zone. And so we actually did get to success. We just need to use a different lens to look through on patients like this, and on all patients. We want to make sure that we take our goals of care in the context of the patient. And so this gentleman is still with us and doing well. He's undergoing chemotherapy. He's also enrolled in palliative care, which you'll hear about later today, which I think is a very important thing to acknowledge and not overlook. I view things like palliative care as a resource. If those resources are helpful for you, then participate in those resources. And if you get evaluated by palliative care and you feel that those resources are not helpful for you, then that's fine. But really, in this patient's care, it's been a very, very positive thing. He is a dancer. He's a dance instructor. He's still able to do all of those things several months after his diagnosis has been made. So we've already covered some patient stories, and again, I don't think I'm going to need a full 45 minutes. We have more here, but I'm going to periodically peek at my watch to just make sure that I don't go over time. We're going to review briefly some thoughts on medications, a little bit of time on some non-medication therapies as well, and then finish up with some lists of some resources, which I think you also already have in your documents. So this bird is the blue-footed booby, which is native to the Galapagos Islands. And the Galapagos are just a really cool place if anyone's been fortunate enough to either be there or just see some pictures and movies from there. It's kind of the epicenter of adaptation, if you will. We could call it evolution as well, but the birds, again, are remarkably adapted. I actually don't remember why they have blue feet, but what's unique about these birds is that their eyes are very close together, much closer together than on most birds, so they do have binocular vision, and they're remarkable fishermen. And so what they do is what's called punch diving. They will be, probably a few hundred feet up in the air, and they'll see the fish that they're interested in having for breakfast or lunch, and then they fold their wings back, and they become quite literally like an arrow, and they punch into the water, and then that's how they get their fish. And the other really interesting thing that I learned is that they actually don't get the fish when they hit the water. What they do is they create such a chaos of bubbles when they hit the water that the fish are temporarily disoriented and they pause for just a moment. And so then the booby, when it's coming back up, is when it actually gets the fish. So again, just remarkably adaptive in their niche, which really no other bird has been able to fill. Happy to answer bird questions at any time as well. I don't know much more than what I'm going to tell you right now, but happy to make it up. So the title of this talk that Joan and I came up with was Optimizing Every Breath You Take. And so in the stories that we just went through, I think for me, the important things with these patients, because they're all different, is to make sure that you understand your diagnosis, that you learn what medicines, and we'll go into this a little bit more in a few minutes here, but learn what medicines might or might not be helpful. We follow guidelines on how to treat certain types of lung conditions. They are far from perfect, and so that's an acknowledgement. And so we want to make sure that we tailor whatever treatment we have to you and what symptoms you might have. As I tell many patients that I have, this is very different than high blood pressure, where we want to dial in the number, and the number is really what matters most, or high cholesterol, where we dial in the number, and the number is what matters most in cholesterol. And all of these things you're here for today are a fair bit different than that. And so learning and understanding those things is very important. The third point is to consider the important non-medication therapies. And again, I'll have several slides on this, and then many of your other discussants today are going to be talking about that as well. Exercise, meditation, mindfulness, goal setting, quality of life, and treating symptoms. So those are the things that, again, I want to make sure that we put out on the table as important things to learn and to understand and things like that. And then lastly, to partner with your healthcare provider to ask questions and to challenge assumptions. We're here to help. We're here to partner with you to have a dialogue. And again, many of these things we do are not straightforward. They're not terribly linear. And so asking questions and challenging assumptions is, generally speaking, an accepted and a good thing to do. I had to put in one slide of the lung to just describe how it works. And I found this simple little cartoon here. And so, as you all are probably aware, the goal of the lungs is to get rid of carbon dioxide and to provide oxygen for the blood. That all happens in an incredibly simple unit here, where there's the capillary that comes in with blood that's deficient in oxygen and rich in carbon dioxide. And by the time it passes that little air sac, the alveolus, the relationship has flip-flopped, and it's now hopefully poor in carbon dioxide and rich in oxygen. Those four numbers really just define, if you will, where lung disease happens. One is the airways, that's asthma, it's COPD, it's things like that. And that's probably the most common thing that we deal with. Point number 2 on the slide is things like interstitial lung disease, which is at that interface of the alveolus, the air sac, and the capillary. And it's normally just 2 cells thick, and so if it becomes puffy and inflamed and full of stuff, whatever that might be, then that's how interstitial lung disease causes problems, creates symptoms, minimizes the efficiency of the lung. Point number 3 is the capillary itself. There are certain conditions, blood clots, pulmonary hypertension, things like that, that affect point number 3. And I put 4 off to the side a little bit just so I wouldn't forget. There's lots of other stuff. The pleura, the fluid around the lungs, those types of things, lung cancer, and other things like that. So I just wanted to make sure that I didn't forget about that. But that's really, on one hand, as complicated as the lung gets, yet there's no shortage of things for us to talk about. Again, most of the action, if you will, is at point number 1, but not exclusively. If I lean a little heavily towards number 1 and you have questions about the other areas and topics, happy to jump into that at the end as well. So on point number 1 is bronchodilator therapy. And so if any of you are on inhalers or nebulizers, this is the category that I'm talking about. On the slides and so on your paper, there's probably a lot of somewhat granular stuff listed out there. And what I didn't really want to do was go through a list of medicines and things like that. So if you have specific questions about medicines, about inhalers, about nebulizers, that you'd like to ask, believe me, we'll have ample time to do that. And so what I want to just focus on is a couple things. The main thing, the main role of inhalers is we want to minimize impairment and we want to reduce risk. We could flip that around and say we want to maximize what you're able to do. So in both asthma and in COPD, as 2 examples, there's pretty good data that says that the inhalers work well for this. They have the opportunity to maximize what someone's able to do, minimize symptoms, keep people out of the hospital, those types of things. And so they are really the bread and butter of our treatment. The important acknowledgments here are the question marks. Which inhaler is best and does everyone benefit? I'm noticing that my voice is kind of moving in and out if people can't hear me at any point, just kind of raise your hand and then I'll try and focus a little more on the microphone. But anyway, those 2 question marks, which inhalers are best and does everyone benefit? There's not a universal answer to them. So again, that's why I want to put these questions out on the table, is to kind of acknowledge what our limitations are. We don't know everything. We'd like to think that we do, but we don't. So that's merely an acknowledgement. We do have national treatment guidelines, and importantly, we want to tailor the therapy to the patient, which is a little bit, again, different than high blood pressure, high cholesterol, things like that. So this bird, and if I miss any birds, let me know. Oh, I want to make sure that I didn't. No, we're good. No, because they're just really cool. And again, for me, they're inspirational. This is a frigate bird. It is known as the pirate of the high seas. So the pirate, a frigate, Frigate, frigate bird. And so it's the pirate of the high seas. And so what's unique about this bird is that its feathers are not waterproof per se, yet it's an ocean-going bird. Its feathers don't have oil on it because it really wants to spend virtually no time in the water. And so what it does is that if another bird, example a blue-footed booby, catches some fish, this bird will chase it, steal it out of its mouth, or be so relentless in chasing it that the blue-footed booby will throw up its fish to get that thing off of its tail. And that's no joke, and we saw this, and so it is appropriately the pirate of the high seas. I think there's probably no bird that it doesn't chase, that it doesn't bother. And so what you'll do is if there's fish, you'll see the blue-footed boobies and other fish, birds coming first, and then 5 minutes later, 10 minutes later, once it's been validated that there's some good food here is when these guys come in to wreak a little havoc on the back end. And they're beautiful birds. They're quite big also. So mentioned in the last slide were asthma and COPD. We have stepwise therapy, stepwise recommendations that we follow. So the National Asthma Education and Prevention Program, NAEPP, has recommendations regarding asthma. The Global Initiative on Obstructive Lung Disease, GOLD, which is probably a term that you all have heard, they have guidelines for us, but I'll again mention that they're guidelines. We have stepwise therapy, and with you, based on how you're doing, we move therapies up, down, left, right, et cetera. And so it's pretty common that over the course of a year, we may, in some people, not adjust anything, but in others, adjust things with some regularity. So without getting into the nuances of those guidelines, let's just acknowledge that they're out there. They're difficult even for us. And so that's where your participation with us is super important in that. Many, if not all, of the medicines come in both nebulizers and inhalers, and so we again try and choose one that might be most effective for the patient. And we sometimes change our mind, and that's okay, because these inhaled medicines are not like pills. It's not like you swallow and just get something in your stomach and you're good to go. So that's why it's a little bit more of a challenge. There are many other medicines, and again, I may have some of them in your handouts, but many, many other medicines that relate to obstructive lung disease, asthma, pulmonary hypertension, et cetera. And so without boring us with a big litany of medication list, again, happy to answer any questions you might have on those specifics a little bit later. Thank you. So this is a heron, just like we have here in Colorado. This bird has the largest range, I think, of any bird in the world, definitely in the Americas. It will eat anything. And so I think its niche, if you will, is it's just happy with anything that moves, doesn't move, et cetera. And magnificent birds. I've not seen ones quite this big here in Colorado, but it is effectively the same species. I believe this is the great blue heron. And again, this was down in South America. I don't know that we ever saw any of these fly. This is what we saw a lot of them do in conserving energy, but also, again, just magnificent, beautiful birds. Again, number one on that slide with the 1, 2, 3, and the 4, the structure of the airways, structure of the lung. There are some conditions like bronchiectasis and occasionally COPD where we have some airway clearance devices, and so I wanted to at least mention these as, again, another category of therapy. The Acapella and Aerobica are brand names of flutter valves. There are vibrating vests. There are nebulized saline approaches that we use as well. And again, the goal in this topic here is airways clearance. And so, again, put on your list of questions if you have specifics that you'd like to learn more or ask or understand about that. This is the Galapagos penguin, and it's the only penguin that doesn't live in an icy clime. And so this type of bird has never really seen ice or frozen waters. And as you're well aware, it has devolved, if you will. It doesn't fly. They swim super, super fast. They're fishermen and small. I think the biggest they'll get is maybe like 18 inches tall, maybe even a little closer to 12 inches. So much, much smaller than the other penguins that you've probably heard of or seen pictures of. And just cute little characters that will waddle around on the land, then jump in and disappear as they go fish. Last category of therapy I think to mention is oxygen therapy. And again, I have question marks up here because our approach or our views of oxygen therapy are modified a little bit today compared to a few years ago. And so we just want to make sure that we ask questions of who might have a survival benefit because it's not universal. We probably used to think that it was a little bit more closer to universal. And is there a quality of life benefit? So the best way to answer that is how does someone feel when they use it? And do they feel that their functional status is improved or not? And if it's used at nighttime, what are the potential benefits? Example, there's some people who might have morning headaches related to a low oxygen level throughout the night. And so we want to make sure that we try and define how does this therapy help you? Because again, it's not universal. And there's a couple questions at the end where we can drill down on the oxygen therapy a little bit as well. And so the last 2 points there are, again, we used to treat the number, but now we want to make sure that we treat the patient more so than the number. We get a lot of questions. Gosh, what does an 88% saturation mean compared to a 90% saturation? There's not great answers for that. Again, with high blood pressure, we know that if the systolic is above 140, well, it should be below. And if a cholesterol is above 200, well, it should be below. And so we, again, think 90% or 88% might be a somewhat magical number. But again, we need to be a little bit skeptical and make sure that we balance those numbers with you, what you're doing, how you're doing, and all those types of things. This bird is the tropic bird. It lives on cliffs in pretty harsh terrain by pretty much everyone's definition, I would imagine. And the tail, the wisp of the tail, is there because it allows it to change directions almost instantaneously. So this might be considered the Ferrari of birds. And so at really high speeds, it can come in and suddenly land right in the cliff. And it can take off suddenly from the cliff and then dive to catch fish and those types of things. I think most of the birds, in particular in the Galapagos, live off of fish. And so that's kind of, they're all associated with the water in some way, shape, or form. But just a beautiful bird, and it moves so fast, and was just out there in the middle of space that I quite literally took a couple hundred pictures to get about 2 or 3 that were in focus or, worth showing. And a bird I had never even heard of or ever even seen. Again, the tropic bird. Just quite beautiful and inspirational. Pulmonary rehabilitation, there's going to be more on this later today, so I'm not going to bore you with the details so much as to acknowledge that the goals of pulmonary rehabilitation are many. Aerobic conditioning, which means strengthening the large muscle groups in the body, example, the legs, because that's how we get around. Muscular strengthening in the upper body to preserve muscle mass, which is also important. Breathing exercises, the things that are a little softer that we don't always think about are nutritional counseling, which is also in the category of pulmonary rehabilitation and an important one to put out there as well. And then behavior modification and smoking cessation for those who might still be smoking, of which there's a moderate number still. And so if you take all of these things that I've just gone over, the biggest bang for the buck is actually probably pulmonary rehabilitation and with certainty smoking cessation. And so it's fair for me to acknowledge to most of our patients, in this zone of smoking and smoking-related illnesses, that if you quit smoking, all of the medications are going to work better, all of the therapies are going to work better, and it's going to just get them down the road a little bit further. So that's an acknowledgement of the importance. And again, smoking cessation and pulmonary rehabilitation are not medications, and they have few to no bad side effects. And so I just want to make sure that we stress the importance of those. And you're going to hear, again, more about those a little bit later today. Hang on. I'm going the wrong. Thank you. Appreciate it. So this is a lava gull. It lives in similar terrain to the tropic bird that we just saw. The tropic bird is on the cliff. This one is back on the tops of the cliff, so it's a little bit more benign terrain. It has the big red ring around its eyes because it's one of few birds that has adapted to be able to fish at twilight and at night. And so its pupils are the big black thing, and it has just excellent night vision. And so it's about the size of a really large pigeon, probably. When we saw this bird, it was late afternoon, early evening. They were just starting to come out. They were pretty inactive, and so they were really easy to just sit down next to and take a picture of. But that's the unique niche that it has filled, is that it has incredible vision tailored to nighttime and twilight so that it can fish when everybody else is packing it in. And so I have one more story of a patient to end with here. And don't let me forget this picture either. This is a very special bird. I met earlier this year a 65-year-old female who was a former smoker with COPD, who underwent lung cancer screening with a CT chest and was found to have a nodule about 1 centimeter in the right upper lobe, and it was biopsied, and it came back lung cancer. Again, a little bit like our mesothelioma case earlier, more challenging, if you will, type of a diagnosis that I also, again, wanted to just make sure we put it out on the table because these things happen. There are still a couple 100,000 people a year that die from lung cancer, and so we see lots of it. It's seen everywhere in all states across the country, and so it's still out there. So fortunately for this patient, she was what we call a stage 1A, and all that means is that she was fortunate enough to have an operation that was curative, and she did not require any additional radiation therapy or chemotherapy. That's kind of the goal, if you will, with lung cancer screening. And so I met her when she was already a couple years out and doing very well, and still with some delayed recovery on some chest topics, but functional at home, independently living, and has resumed most of her activities. The lung cancer screening is an emerging topic, so what I'll mention is that it's worth considering for people between the ages of 55 and 77. These are Medicare guidelines, and they're pretty reasonable, which is saying something for Medicare. So between 55 and 77, either still smoking or having quit within 15 years, a 30-pack year history, and able and willing to undergo treatment for lung cancer if it is diagnosed. So those are the criteria, and I say worth considering. Canada, they say anyone in that zone should have annual screens for about 3 years. And then if you're good to go after 3 years, then they kind of close the chapter on that. Canada is basing that on a pretty good study where they looked at patients over a 5-year window and did 2 screenings in 5 years and had favorable outcomes. So Canada is not being cheap if they stop after 3 years. They're actually being prudent. They're acknowledging the risks of radiation, exposure, repeated tests, people worrying. We find a lot of things on lung cancer screening that are not cancer, and so we worry about a lot of things. We worry about more lung nodules than are actually lung cancer, far and away. So that needs to be acknowledged. But anyway, the categories, the criteria, the Medicare requirements, we just went through real quick. And I'm going to say it's an emerging area because we just don't have perfect data. We think that we save lives by screening and finding early lung cancer, but it's not a slam dunk nearly as much as things like mammograms or colon cancer screening or cervical cancer screening, things like that. So that's where this is an important one, to have a dialogue with your healthcare provider about if you fit into that category and feel it's worth considering. And then I'm a bee photographer, like I'm a bird photographer, if you will. They're just really hard to photograph. They're just ridiculously small. They're gone before you can even press the photo button. So this is one that I took a few years ago. We most years have a bee colony in our backyard, and we just live in kind of central Denver, and lots of clover growing in the grass because we don't necessarily do an awesome job of keeping the lawn weed free. And so I can just kind of lie down in the grass for, an hour or so, and just lots of bees come up. And so this is one of my best ones where it behaved and it was calm and facing away from me so you could see the colorful stripes. But again, they're usually gone pretty darn fast when you get around to taking pictures of them. So I thought I'd just share that one with you as well. Again, not a bird yet, still just a, inspirational thing. So I'm going to summarize here. This is what we started out with. It's important in all of the cases that you understand what your diagnosis is, and that it's okay to challenge that and make sure that both you and your provider are comfortable with that. There is great opportunity to learn about things like medicines, and the usual story with physicians is you just show up and you get a pill and then you move on down the road. But really, this is a much more complicated zone than that. And so we acknowledge that, again, medications might or might not help. And so we just want to be, I use the word skeptical. There's probably better words to use. But I think if we fall in the camp of being thoughtful minimalists, where we think about a lot of things, but then don't just pour more medicines on everything, that's probably a good way to go about it. And so learning this and acknowledging that we have guidelines but not hard and fast rules is important. And then the red box here is really what I think the rest of today, or a lot of today, is about. And it's going to be those non-traditional, if you will, the non-medication therapies that include exercise, meditation, mindfulness, goal setting, quality of life, treating symptoms, and defining for you what success is, not defining for me what success is, because it's really not about me. And so I think that's probably the most important thing. Again, partnering with your providers, which includes your DME company sometimes, which includes your physicians and nurse practitioners and physician assistants, and making sure that we can collectively get you down the road a little bit further. And then lastly, enjoy the rest of today, because I think there's a lot of awesome stuff. And again, I'm honored to have been able to speak with y'all for a bit this morning. I do have at least one more bird picture. So actually, let's do this. We're going to go backwards. This is the last slide that gives some resources. I believe it's in the handout as well. That is a stilt bird. It's either called a black-necked stilt bird or a black-winged stilt bird. It's pretty small. I'm going to say maybe game hen size, maybe a little larger. And as you can see, it has its legs where it gets its name. And the niche here is that there are some bodies of water in the Galapagos that are pretty much uninhabitable because male sea lions that are not the alpha male of a colony of female sea lions, they kind of get booted out, and so there's a lot of rogue males, if you will, or lone wolves, if you will. So they go to these little areas where they just kind of hang out, and so the water is so full of acid and stuff from their living and their excrement and all that kind of stuff that really not much lives there. And so there's some bugs, some slugs, some snails, things like that that can live in the water, And so this bird has adapted so that it is able to eat. It pretty much has a smorgasbord in any of those areas, and it has no shortage of stuff to eat because it's the only one that shows up there. And so again, just a pretty cool, adaptation to make sure that it can survive and thrive in a seemingly otherwise harsh place. So, happy to take questions. And here are some that Joan put out for me. And so I can go through these versus we can first start out with your cards and what you've written down, but there's a few others to have us think about if we run out of questions.
If anybody has a card, can you put your arm up so we can grab it? And bring it on up, please.
So, what is the effectiveness of benzonatate, which is also called Tessalon, I believe? And if I get these names mixed up, correct me. We're supposed to know the generic names, and I sometimes get the trade names mixed up. What is the effectiveness of benzonatate for a patient with IPF and asthma? So benzonatate is something that can be used to help with cough. And the entire category of cough medicines is very subjective. There is probably some data that says they're helpful and they're worth considering, but they definitely do not work in all patients. They are safe, and so it's worth undergoing a trial of these medicines like benzonatate to see if it helps your symptoms. But really what you want to do is you want to decide, well, where am I starting with my cough? Example, it bothers me 25 times a day. And where am I going to finish after, let's just say, a 2 to 4 week trial of something like this? And so, example, am I coughing now 15 times a day instead of 25 times a day? So again, very subjective, but that's kind of the best we have. So another way to answer the question is, do we have evidence that benzonatate saves lives, reduces hospitalizations, reduces the likelihood of a bronchitis or an infection? The answer is we don't. So again, it's a symptom-driven medication that we want to make sure if there's a benefit in that we use it regularly, that you define what the benefit is. Next question related to that is, why take the med if the objective is to expel mucus by coughing it up? So I'm going to rephrase this question here. People logically worry, wow, if I have a cough and I have phlegm and I'm supposed to get it out, what happens if I suppress the cough? Let's rewind the clock maybe 100 years or so, back when there was a lot of tuberculosis. In that era, we used to feel that you had to cough the tuberculosis up and out so that it wouldn't get into the body because it's resistant to acid and it might, who knows, disseminate throughout the body if you swallow it. There's not complete truth to that, but that was part of the theory behind getting stuff up and out was our experience with tuberculosis. So these days, as gross as it sounds, I'm sorry, if you swallow whatever comes up and out, it's not going to hurt you. And so just acknowledge that. And so again, this is the balancing act. There is one category of lung disease called bronchiectasis, where that type of a person will make a quarter of a cup to a half a cup to a cup a day of sputum. We just can't turn the faucet off. We would love to figure it out, but we can't. So that's one example where everything we can do to maximize the expectoration and getting it up and out and making it easier to get it up and out is really what we want to focus on. But if there are acute episodes of illness where you have a cough and it's pretty relentless and you can't sleep at night, it's actually not harmful to most of the time to use a cough suppressant or another thing like that. So that's on the cough. Is pneumonia vaccine an annual vaccine like flu? So I'm going to give you 3 answers here. The flu shot is annual, and it changes every year. And if you get it right around now, you should be good to go for, the next few months. If we have a really protracted flu season, then it might be worth in January or February asking your provider if you should be revaccinated, because the sweet spot for these is probably in the 3-month window. So just keep that one in your back pocket. Pneumonia vaccine. There's now a 2-step pneumonia vaccine. The first is called, and the order is not quite as critical, and I might actually have it backwards, but Pneumovax 23 is the old-fashioned pneumonia vaccine. The new one is called Prevnar 13. You need them both. You get them a year apart. if you already got the if you already got the Pneumovax, which was the first one, if you already got it, you can get a booster after 5 years, and in particular for people aged 65 and older. So that's a pretty close approximation. It may not be perfect, but pneumonia vaccines, there's now 2, Prevnar 13, Pneumovax 23. You get them both 1 year apart. That's the way to do it. Does high THC cannabis oil work for COPD? So the fortunate and unfortunate things about Colorado and THC and marijuana is we just have lost probably the ability to study this objectively because you can get anything that anyone suggests to you. And so I don't have a terribly good answer for this. Again, I would look at it as what's your goal with using THC? What symptom are you trying to treat, and kind of try and be as objective as you can before and after. So my rules for these off-label medicines, if you will, these non-prescription medicines, non-prescription therapies, including things like stem cell, for example. 3 questions in no particular order. Number 1, is it safe? I had a patient use medical marijuana quite a while ago, back when before it was legal to have, recreational marijuana. And he said, I have chest pain, I'm stage 3 lung cancer. It actually might have helped with my pain, but I was so dizzy, I was worried sick that I was going to fall, and I stayed in my chair for 4 hours, and I didn't get up for 4 hours because it was so potent. And so we never used it again. But the point is, take that as, well, what is safety for me, and how might something like this affect me? So number 1 question would be safety. Number 2 is cost. And number 3 is benefit. And so again, these things like marijuana, THC, oils, et cetera, very subjective. Figure out where you're starting. Figure out where you want to end. And if your goal is to feel better, that's kind of not specific. And maybe that's good enough, but if there's a more specific thing that you can focus on, that would probably be helpful. I can just grab the whole stack. Yeah, that's fine. So again, people raise hands, redirect us at any point. We got a few minutes here and a good stack of cards here with questions. Are there types of COPD or just stages? So to back up for a minute here, COPD is a little bit of an umbrella where it's chronic obstructive pulmonary disease. And does asthma fit under COPD? Kind of, sort of, maybe not, but sometimes it does. So this is one of those things where we haven't really done ourselves a great service with some of these names that we have come up with. But if it's chronic and it's obstructive, that's asthma, and it's pulmonary, that's the lungs, then again, asthma could fit under the COPD umbrella, but not usually. So that's one thing worth ferreting out. I would say this is going to be an oversimplification. If somebody used to smoke or smokes, it's probably COPD. And if it's somebody who is a never smoker, it's probably asthma, yet there's a big gray zone in the middle. And so therapies might vary based on what you and your doctor decide on that gray zone topic of where you land in that spectrum. So if we talk about emphysema, which is smoking-related lung disease, there's generally just one type of it. Although if you get into radiology literature and pathology literature, there might be different types, but there's generally just one, and it's smoking-related. There also is alpha-1 antitrypsin deficiency, and you don't necessarily have to be a smoker to have COPD or emphysema from AAT deficiency, yet it has that common pathway of emphysema and COPD. So it really behaves the same with some maybe subtle differences, but it's pretty darn similar. So long-winded way of saying probably there are not terribly many different types of COPD. They generally all behave in a spectrum. And the stages are 1, 2, 3, 4 by GOLD criteria: mild, moderate, severe, or very severe. And so I will merely say that those adjectives, mild, moderate, severe, very severe, they're kind of emotional. And so I don't always find them terribly helpful. I can have somebody with seemingly mild by numbers COPD who's not doing terribly well and not terribly happy with their station in life. There's others who are stage 4 or severe or very severe. They're doing pretty well. We used to say FEV1 of 1 liter and below. well, we could still say this. That type of a person with an FEV1 of 1 liter or lower, they might not be with us in 10 years. They're probably not going to be with us in 10 years, maybe not in 5 years. But our ability to read the tea leaves for any given patient is not awesome. We get this data from populations. We look at 1,000 or 10,000 people with this type of lung function, and we decide, well, how many of them lived and how many of them passed on? And that's where we get our numbers from. So again, we can't apply that to individuals. And so again, with your doctor, mild, moderate, severe, very severe, 1, 2, 3, 4, don't read too much into that. What does 30-pack year smoker mean? How we think of smoking, it is definitely a dose-related thing. If you smoke a pack a day for a year, that's 1 pack year. If you smoke a half a pack a day for a year, that's a half a pack year. So that's how the math works. And so what we do on the lung cancer screening is the high-risk population has been deemed 30 pack years or greater, and that's probably a reasonable number, again, based on studies. So a pack a day for 30 years, 2 packs a day for 15 years, half a pack a day for 60 years. All of those are a 30-pack year history. So that's how you get to that number of 30. What is the relationship between chronic bronchitis, pneumonia, and lung damage? So this topic here is as follows. The very first case we showed, which was asthma, my concluding comment was don't be a stoic and don't be a hero. If you're in a category where recurrent infections happen, where recurrent pneumonias happen, you probably want to talk with your doctor about it, because there is a subset of people where recurrent infections is not awesome. Recurrent infections could promote further lung damage. Bronchiectasis is one example. Could promote further lung damage, and so we really want to be as proactive to interrupt that infectious cycle as possible. We also acknowledge, though, that there's downsides to being liberal with antibiotics. And so that's where, again, you and your provider need to talk about this to decide, well, what is the diagnosis and what are our goals and how do we get there? Because of the upsides and the downsides. So it's also fair to say, though, that not all chronic bronchitis that someone might have is going to, necessarily put them in the grave early and be a horrible progressive thing. Not all pneumonias are necessarily going to be a huge setback, but they might. So I can't get more granular on that answer except to say that, again, recurrent infections may be a bad thing in some people. Get your vaccinations. Don't be a hero and seek evaluation prompt. Have an action plan. For some people with COPD, it's appropriate for them to have maybe an antibiotic and prednisone at home in their medicine cabinet so that at Friday, 4:30 p.m., 3-day weekend, you start feeling bad. Wow, what do I do now? And you can't reach anybody, and so then you go to the ER. ERs are there for a reason. I won't say it's the last place you want to go so much as, again, if you and your doctor have a script worked out for what to do, then you're probably going to fare pretty well in that situation. How old to buy e-cigarettes? I'm going to guess 18. Any clinical trials or for stents? So let me pause on the e-cigarettes. Everything you heard on points 1 through 5 just a little bit ago are correct. I know people who have successfully used them to get off of cigarettes, so I try and not take an approach of, judgment so much as huge congratulations, you're off the cigarettes. That's really good news. I think probably e-cigarettes are the lesser of two evils, but with certainty the data is not in yet, and I'm going to predict in another 5 to 15 years, we're going to have pretty good data on e-cigarettes. It boils down to this. It's all particulate matter. If you suck stuff into your lungs and that stuff lodges in the lungs, that's not a good thing. And so that's really the bottom line on the e-cigarettes. Are there any clinical trials for stem cell research? The answer is no. And so question number 1 up there is, what is the role of stem cell? It's unknown. There are research trials going on. I don't know that there's any going on here in Colorado, but I would encourage people, if they're interested in something like this, to pursue a research trial, as opposed to, there's probably half a dozen stem cell shops around town. Nothing against them so much as we have no data. And so there might be benefit, but you got to ask the question, is it going to put me in the poor farm? and is it safe? And anytime you have therapies that involve blood products, removing stuff from your body, doing magic with it, and then putting it back in your body, et cetera, there's risks. So that's my only caution on that one. Why inhalers or over nebulizers? This all boils down to technique. If you have the ability to have hand-mouth coordination, a handheld inhaler is fine. It's worth reviewing about a dozen times with you and your provider, because I've had people come in and they have perfect technique except the inhaler's upside down, and when they're upside down, nothing comes out. I've seen that. And then I can't, there's a handful of other just very creative ways that I've seen the inhalers used. So bottom line is technique matters. And so that's the limitation of the nebula, the inhalers, the little MDIs, is that technique matters. And so nebulizers in a certain population are going to be more effective due to it's more liberal with technique, and there's probably more side effects with things like albuterol. I'm going to power through these. Are we out of time?
Well, we're talking about, would you be willing to answer the questions on our website?
Oh, sure.
And like they wanted to know answers to some of these.
Yeah. So I'll be able to get some answers on the website as well. What role does marijuana, chemical, chemtrails, industrial, and red tide have on lung health? The generic initial answer on this one is going to be particulate matter, bad, clean air, good. And so again, originally a lot of people said, well, marijuana's not bad for the lungs. We've studied this. That's actually not correct. I have patients who smoke nothing but marijuana. They have COPD. They've never smoked a cigarette in their life. And so it happens. And then chemicals and other things that are, inhaled have potential bad things. I actually don't know about red tide. And I have heard people talk about it. I'll have to admit that I just know nothing about that. Can inhalers or nebulizers help with primary pulmonary hypertension? There are some inhaled prostacyclin therapies, so the answer on that one is yes. But again, that's a really specialized area of medicine. So people like Todd Bull and David Badish and others at the university are probably the national experts on that stuff. And then pulmonary hypertension with COPD is a more challenging topic, because that puts you possibly in what we call secondary pulmonary hypertension. And so usually those inhaled type prostacyclin therapies are not used. Pulmonary rehab and PPH, yes. Pulmonary rehab with almost any pulmonary diagnosis is worth considering. Is the price of inhalers ever going down? Yes. They were on the cusp of becoming generic when the government said we can't use Freon anymore. So all of the companies had to remanufacture their stuff, do safety studies, and they got new patents. I don't know when they're going to be going off, but hopefully soon. Prescriptions from Canada, totally legit, worth considering. Interestingly, here's a question. The 63-year-old patient with mesothelioma, what was his exposure? He had none. The classic is asbestos, Navy, ship rooms blowing insulation into the boiler rooms, and he had no exposures. So it happens. It's rare, but it happens. Last question I have is here, will keeping my oxygen saturation over 88% prolong my life? I'm going to lean towards not necessarily on this one. If somebody has a low oxygen level all the time, 24 hours a day, you're going to be more likely to have cor pulmonale or congestive heart failure. But again, is an 88 better than an 87? And how does that weigh in comparing a 90? Again, it's worth having a critical discussion with your doctor on that. If you're 88% and you're doing light activities and you feel good, are you safe? The answer is you are. But a little bit of common sense goes a long ways, and that's why whenever there's a man patient, I'm glad that if they have their wife with them, because the wives have more common sense, is my experience. That again, you want to feel, you want to be safe. And so you have less room for error, if you will, maybe if you're at 88. But again, light activities around the house, in the kitchen, you're safe at an 88, generally speaking. But again, a complicated topic where there's emerging data that says, not doubting the benefits so much as allowing us to at least question it and look at it in the light of you and safety. Thank you very much. I hope that was helpful.